Good morning, everyone. I hope you can hear me okay. Welcome to week 8 of Cardio Echo Weight Management. If you could please chat your name in the box. I see many people are already doing so. Thank you very much. Remember to mute yourself and unmute yourself if you wish to speak. If you're on the phone, you can use *6. And there's a phone number here if you have any technical or audio-visual problems. I'm going to introduce the room here at the hub, and we have Dr. Rao joining us remotely. I'm Shannon Switkowski, the clinic coordinator.
I'm Jim Warner, behaviorist.
Jesse Lewis, program manager.
I'm Rick Carnaccion, web content producer.
Dr. Rao.
Good morning, everyone. I'm Goutham Rao. I'm the director of the series.
Oh. Is he still on? Dr. Rao, did you start?
Yes.
Oh, go ahead.
Okay, thank you. So thanks for joining us. I can't believe we're into week 8 already. You can see our disclosure statements here this morning and read those when you need to. I, as a presenter, don't have anything to disclose financially. Next slide, Rick. So this session is called Social, Environmental, and Cultural Influences Upon Weight. Why do we include this session? Because we certainly, as individual clinicians, can't do a whole lot about these things. But in our understanding of them, I think, we will hopefully develop more empathy and more understanding of our patients and develop individualized approaches which take these factors into consideration. That's why the National Academy of Medicine and other organizations recommend that clinicians do understand some of these factors. What I'm going to present to you is in some cases largely based on my own experience. The reason is this is one of those great under-researched areas of weight management that we don't really have great evidence, and there's a lot of conclusions, a lot of politics involved, etc. So bear that in mind as we go through this presentation. Next slide, Rick. So you should be able to explain how family and other relationships determine body weight. And a lot of this is just epidemiological. It doesn't apply to individual patients, but nevertheless, I think it's important. List and describe a minimum of 3 environmental influences upon weight. We'll talk about that much more next week. How cultural factors influence body weight, and list and describe a minimum of 2 culturally sensitive approaches to weight management counseling. What I'm going to present to you near the end of my didactic presentation is a case study that I'd like us all to consider in terms of how we approach the issue. Next slide. So I'm the author of used to be a popular book called Child Obesity, A Parent's Guide to a Fit, Trim, and Happy Child. It came out, it's published by Penguin Random House through Prometheus Books, published about 13 years ago now, hard to believe, or maybe 14 years ago. And I did a lot of research. This was back in the early 2000s about childhood obesity. Now we're talking about adult obesity, but nevertheless, I think this is relevant. Part of my research was looking through old school photos going back from the 1930s across the US and Canada. And of course, what I noticed is that there were no children who had obesity for the most part. Next slide, Rick. You could go, and this I think is from the 50s. There wasn't a single one that was obviously obese. Next slide. A class with a lot more diversity. Still, nothing. 1972, not a single kid who we would, say visibly had obesity. Neither does the teacher. Next slide. And it went on and on. And you look at different cultures. Now, this is a picture, believe it or not, the Pima Indians back in the early, I think in the 1920s. Now, the Pima Indians have the highest rate of obesity of any group in the United States. And I think among adults, nearly 70% have type 2 diabetes. Not a single, this is just one picture, not a single picture showed anyone, adult or child, who even looked the slightest bit overweight back then. Next slide. And I show this picture, people think it's an impoverished picture from the South, and it's probably from the 19th century. No, this is from the 1950s, it's from Pittsburgh. And that was the sort of poverty, I think, that was obvious in this photo. Next slide. So something happened, right? There was a dramatic transformation of our environment. there are probably some changes in culture that took place. What we can say is that the genetic population of the United States has not changed so dramatically in 50 or 60 years that that's the reason we have so many children and so many adults who have obesity today. This is my effort to look at the problem initially. This goes back about 5 years or so. And this is another statement from the American Heart Association called Identification of Obesity and Cardiovascular Risk in Ethnically and Racially Diverse Populations. It is purely clinical. It deals with different standards for waist circumference, metabolic profiles, BMI, etc. It says nothing about culture, and that's very deliberate. We stayed away from this issue because we weren't sure how to approach it. I was the chair of the AHA's obesity committee at the time. Tiffany Powell-Wiley was my co-chair. She became the chair afterwards. She's an African-American cardiologist from Maryland who has a great deal of interest in this area. And Tiffany, I would sit down and say, I don't understand why. What happened? Why do we have some cultures who are so overweight and in others there aren't that many factors? There's some subpopulations. And so I think it gives you some idea that this is a very challenging topic to study. And what we do know is certainly controversial. So next slide, Rick. So what are the factors? Why do some people become overweight or obese and others not? Well, when we look at the diverse population of our country, acculturation has a lot to do with it. The most studied group is the largest minority group really in the United States, and that's the Mexican Americans who, as they become more accultured to the American culture, tend to become more and more obese. So the highest rates of obesity are in those who are more Americanized, who have adopted American habits. And that's not just Mexican Americans. The other classic group that studies is Japanese Americans. Japan has a very, very low rate of obesity, but Japanese Americans in Hawaii have a much higher rate, and that is attributed to acculturation. Race and ethnicity has a lot of influence over obesity rates. So there are great discrepancies between specific racial and ethnic groups, which is not surprising. Most people know this, of course. But why is a question that is not really certain. So Mississippi is often cited, for example, as having the highest prevalence of obesity in the United States. But it also has the highest proportion of African Americans in the United States. And that's probably why it gives it such a high prevalence rate. Historical norms are important. Historical norms changed in the early 20th century. And there was something called the moral model. So prior to that, in the 1800s, for example, there were people who had obesity, but they were not necessarily seen as undesirable in any way. In fact, it was, even further before that, it was seen as a sign of prosperity and in some cases actually good health. There weren't many of these folks around. But in the early 20th century, morality took hold. So obesity became associated with lack of self-control, with overindulging when the people around you didn't have that much, with sloppiness, untidiness, many of the social characteristics we associate with it today. And so, it goes back quite a ways that thinness was desirable in the year 1900, but that's quite a long time that the model, the norms for human body shape were established that long ago. Sex has a big factor in terms of whether people become more obese or not. Women have higher rates of obesity across the population, although the disparity among white women and white men is relatively small, but it is there. The other thing is that the social value of thinness, ironically, is much, much greater to women. I mean, there are economic estimates in terms of how much it contributes to your job, to whether you get promoted, marriage, retirement, everything. The value is huge, and of course, most people, men and women, recognize that when you watch TV, for example. Thinness is hugely valuable. Age is important as a factor that determines obesity. Here's an interesting tidbit. So you gain weight mostly between ages 25 and 34. If you're 35 and you have not become obese at that point, your chances of becoming obese goes down significantly. So that by the time you're 45 or 50, it's very, very unlikely. Unfortunately, if you are obese at 35, that's going to be a lifelong struggle for you as well. But that's the period of greatest weight gain, especially for men. Body weight peaks around age 60 and begins to decline, believe it or not, after that to some degree. Other factors, beliefs, and perceptions. There are differences among racial and ethnic groups. And I've said this before, I think that they are somewhat overblown. They are not. That some people are able to tolerate obesity or care less about obesity isn't supported by the number of studies that we have. Next slide, Rick. Employment, unemployment is associated with obesity. I don't think that's too surprising. And you know, some of the case studies we've gone through so far in ECHO, there was the youngish gentleman, I think he was in his 40s, that we discussed a couple of weeks ago, who weighed over 500 pounds and lived in a rural area and really was not employed and hadn't been employed for many years. And that is unfortunately very, very common. Occupation, these you can already imagine. White collar occupations are associated with lower rates of obesity. The richer you are, the thinner you are, the more educated you are, the less likely you are to be obese. That's been known for a long time. But here's something else that's interesting. If you live in a large household, you're more likely to have obesity. And nobody really knows why that's the case. Maybe there's less attention paid to nutrition if you have 5 children versus 1 or 2. I don't know. But on the other hand, if you live by yourself, also more likely to become obese. So this is purely epidemiological evidence. And so you cannot apply this to individual patients, but something to keep in mind. Marital status is very, very interesting. Married men are heavier than their single counterparts. That's kind of a well-known phenomenon, but the synchronicity phenomenon, which has been written about extensively, is fascinating to me. So wife is trying to lose weight, husband loses weight along with her, but is really not participating in the weight management effort, or vice versa. And of course, as well, they're eating healthier, you know, she's the primary food shopper, etc. Things are improving. But even then, there's something else going on that we don't really understand. Parenthood, there is 2 important factors to distinguish. One is childbearing, which is associated with an increase in weight, and child rearing, which is also associated with an increase in weight. But childbearing is the one that's been most widely studied among women. I worked with a colleague back in Chicago. She wanted to study this phenomenon and found from a purely epidemiological standpoint, that after having a child, if a woman does not lose the excess weight that she gained within the first 6 months, she's never likely to do it. And that's a critical period. Again, who knows why these things happen? Are they physiological? Are they cultural? Are they economic? Uncertain. Next slide, Rick. So here's a troubling trend I want us to focus on. And I focus on it because Jim and I have a very diverse practice. And I would say, and I don't know, Jim can correct me, I think about 40 to 50% are probably African-American as well, or maybe even higher. This is the group that has the highest rate of obesity in Ohio, in the United States overall. 60% have a BMI of over 30. That is roughly 400,000 women here in Ohio, including many young women who are likely, if they have not already done so, to develop diabetes, heart disease, hypertension, osteoarthritis, obstructive sleep apnea, and the list goes on and on. Why? Well, that's the big question. There is not one single satisfactory explanation. So I've read about this, and I've put together some things over the last few weeks, I think, that are interesting to observe, but there isn't a single explanation. Next slide. Genes. Is that a possibility? Yes, it is. Adiponectin. So adiponectin is associated with rates of adiposity, tends to control adiposity. People of African background and women in particular have lower rates of adiponectin. Why do we know that this is an important factor? In South Africa, you see the same disparity. South Africa is kind of that middle income country, which actually has very high rates of obesity, like Mexico, India. China is an exception, of course. So there's plenty of food around. It's not very good food. And people are just, getting into a middle-class lifestyle, et cetera. But 70%, when they say overweight, they actually mean BMI of over 30. 70% of South African women have obesity, 39% of men. So the similar disparity that we find here in the United States. Now, one can argue that there are cultural factors that are similar, but I really don't think that that's a big issue. I think that, when you think about South Africa, it's pretty different than the United States culturally. But we see this, and that tends to lead us to believe maybe there is a genetic component here as well. Next slide. Attitudes and concern. There is very little evidence that African American women are less concerned about obesity. In fact, overall, and I don't know if it's in this series or another that I showed, actually there is a higher rate of concern among African Americans about obesity because that community is more severely affected. Families are more severely affected. There's rarely any family that's not affected by stroke or diabetes and has not seen the consequences. So it is a serious issue, and that's reflected in the evidence that we have. Built environment, poverty, deprivation. So this is often cited, and we're going to talk about this next week. For example, the concept of food deserts, which has been challenged greatly. And we'll talk about why it's less important than we think. Yes, African-American families have higher rates of poverty, live in communities that don't have as many supermarkets, recreational opportunities, etc. That's all fine. But surely those factors also affect African-American men who do not have any significant disparity in terms of rates of obesity with their white counterparts or the general population. So is that a satisfactory explanation? No, it's not. Here's what the current thinking as of 2018 sort of thinking is. There are big, big disparities in physical activity between African-American women and other women, as well as African-American men. And why? Well, here's one article by Hall that I'm happy to share it to you. That may have to do with hair, for example, and accommodating hair for exercise. 1/3 of women exercise less frequently because of hair care. 40% avoided exercise altogether. That's a possibility. Nobody's saying that's the sole explanation, but it seems that the more robust studies of physical activity show that there is a big disparity between men and women, which may explain the higher rates of obesity in African American. So that's what we need to go. So if you start to go, if you're in a clinical encounter, you say, I've got this woman, she's 300 pounds. We have women that are very high functioning in many ways. And I just don't know. I just don't think she cares as much about losing weight. That's certainly not true. Or I think she probably lives in an environment where there's just no opportunity for her to achieve a healthy weight. Probably not true either. But let's look at some of the factors that may be there, and it may be weight management, it may be physical activity as a significant one. Next slide. So based on that, here's another completely different approach. So I am a co-investigator for this study that is called the South Asian Healthy Lifestyles Initiative. It's in Chicago. The PI is based at Northwestern, and my role is very, very limited since I only get to the study site about once every 3 months at most for a day. But it's so I'm obviously of South Asian background, and we have very high rates of obesity, diabetes, you name it. It's a terrible problem despite very high levels of education and income. So which is even more paradoxical, and this disproportionately affects women. So the co-PI, Dr. Kandala, looked at what's going on here, and it does deal with physical activity. So especially among first-generation immigrants who are unlikely to go to gyms and join aerobics classes, cultural norms around modesty are very, very important. So she started this initiative, which is essentially a diabetes prevention program that deals with women exercising together and it's more of a social opportunity than anything else, and it seems to be working. But the reason I think that it's successful is it approached the issue from a culturally sensitive standpoint, from a deep understanding of culture and what the barriers to physical activity are. That's what we need across the population. This is a very relatively small study in one small segment of the population, but nevertheless, I think is an important example of that. Next slide. So let's consider this particular example. I'm gonna maybe go out to the group and see what you guys think. So Gloria is a 35-year-old African-American woman who works as a receptionist in a law firm. She completed high school in 2008. She lives with her mother, who's 61, two daughters, 14 and 12. She doesn't smoke because she doesn't drink, no medications. Health is generally, she's pretty content with her health. She feels she's healthy, but you are concerned about her weight. She's 5'5" tall, 264 pounds. You've already opened the door. She said, you know, I'm worried about your weight. It's putting you at risk for all these conditions, even though you don't have them now. Would it be okay if we discuss this further? Is that something you're concerned about? She says, yes, I would like to discuss it further, and I am motivated to achieve a healthier weight. Interestingly, she's the only family member who has obesity. I want you to consider how you would consider physical activity in a culturally sensitive fashion, how you ask about it, what you would tell her, and how might you open that discussion. So let's see who we have on here. I hate to pick on people, but how about Laura?
I think I would ask about if there's any type of exercise or sports that she's ever been previously involved with in the past, to see, you know, gauge a sense of interest of something that she had already previously done. Perhaps ask about, you know, if she knows of any resources that are already in her neighborhood or close to work, places that she, you know, may be able to engage with.
Okay. So I like that approach. It's often, I think you're getting at the same sort of thing. Is there a type of physical activity that you enjoy? I wouldn't, you know, maybe it's not sports. And
Sure.
Is there something that you would sustain and to be involved in? And so we've done this with adolescent girls a long time ago, and dancing was the #1 thing in this community, which, you know, I think a lot of girls, regardless of their background, would enjoy. I don't know about a 35-year-old law firm receptionist, but you know, you could ask, well, give me some examples of things you might enjoy. That might be a way to start the conversation. Okay. Anybody else with any other sort of approach? Kriti?
Yeah, I think I would start with talking about, she's already motivated to exercise or to achieve a healthier weight. So I would segregate diet and physical activity, kind of gauge what's her baseline. And if she does something right now, does she have family members that join her to walk? Starting simple is what how I would approach it.
Yeah, so that's generally good advice. So as Laura said, you know, what do you enjoy, but what's she doing now? Maybe she is active in some way, but you know, maybe she's probably let's say she's completely sedentary. I think the other thing I would want to ask about is, you know, and you can frame it in different ways. But let's say, for example, she says, well, I'm completely sedentary. I don't do anything. I'm not physically active at all. I don't exercise. But when I was younger, I used to play volleyball, or I used to be a cheerleader, or I used to enjoy dancing. And you can ask, you know, well, what are some of the barriers to that now? And how might you be able to overcome them? And she might say, well, if she's got a busy job, she's got a family, And maybe it's not a priority, or she doesn't know how to get started, or she feels that, she has some barriers in terms of her own appearance and preparation for it, which many people do. She says, well, I kind of feel embarrassed because of my size going out and exercising. Well, she doesn't have to exercise with other people, and she can find means of doing it that are very, very appropriate for her, where she feels comfortable, essentially. So those are some of the things that you might want to do. So one other question before we move on is, what would you tell her about how much physical activity she ought to do? Would you refer to the CDC guidelines, or would you do something a little bit different?
So I generally start by saying that you should figure out what your baseline is and then increase it weekly and keep a more sustainable schedule. And then I tell them what their goal should be, or this is the recommendation, but don't worry about getting there tomorrow.
Yes.
Start slow and then get there. That's the approach I advise.
And that is a great approach, Kriti. Let me kind of summarize what she said. But let's look at what your baseline is and increase your level of physical activity gradually. You do not, start with, the CDC guidelines for adults with physical activity, 30 to 60 minutes of moderate to vigorous physical activity daily with some resistance training 3 or 4 days a week. And that's what's needed to maintain good health. Well, of course it is. That's true from a purely physiological standpoint. From a practical standpoint, it makes no sense at all if somebody's completely sedentary. The first thing, I think, is to get her to try something different. So in the pediatric literature, sometimes when children are young, they have to try 5 or 6 different things before they find the thing that really grabs their attention. And unfortunately, it's often driven by what the parent wants them to do. So dad wants him to play football, but he doesn't like football. He actually likes dance, or mom wants her to become a figure skater, but she can't stand figure skating. She wants to do something. She wants to play volleyball. That goes on for years sometimes with children. So you have to try multiple different things. So you can say, hey, look, I don't expect you to lose any weight with the amount of physical activity that you're going to be doing over the next few months. That's not the goal. The goal is for you to do something that you enjoy, and as Kriti said, is sustainable. That's it. You don't need to count the number of steps. You don't have to worry about burning a number of calories. It's not going to happen, right? But if you enjoy walking, let's just get you walking for a few days a week, perhaps, and then hopefully every single day, get you moving for at least 30 minutes. And then we'll see where we can go from there as a starting point. Okay, so that's probably the best way to do it. And as she talks about that, we can ask for her own suggestions. Some barriers to that might come up. Maybe she. Thank you. Any questions for Amy?